Good morning, everyone. So today's topic falls in older adults more than just a stumble, and this is done by Dr. Sithira Senevirathne. Let me give a short introduction about him. And Dr. Senevirathne is a consultant geriatrician at the National Hospital of Sri Lanka. Dr. Sithira Senevirathne is a member of the British Geriatric Society and the International Parkinson and Movement Disorder Society. He is also an appointed tutor at the International Association of Geriatric and Gerontology. In addition to his clinical work, he is an active researcher and academic with numerous presentations at national and international conferences. His contribution range from perioperative delirium and hip fracture outcomes to studies on Parkinson disease, fear of falling in the elderly, tracheostomy and neurological case reports. He's also involved in important global research collaborations, including the Chelsea 2 trial on hydration in end-of-life care. Beyond his research and clinical achievements, Dr. Senevirathne has pursued further professional training in osteoporosis, perioperative medicine, cognitive assessments, and Parkinson's disease, reflecting his commitment to advancing geriatric care both locally and internationally. With his expertise and passion for improving the health and quality of life in older adults, we are honored to welcome him today. And on a personal note, he is my own batchmate from Colombo Medical Faculty, which makes this even more special. So please join me in warmly welcoming and inviting Dr. Sithira Senevirathne to deliver his lecture. Dr. Sithira, over to you.
Thank you, Dr. Lanka. Right, let me share the screen. So today we're going to talk about one of the most important topics in geriatric medicine, which is falls. And so coming into why we are discussing geriatric medicine these days is because of this demographic change. Sri Lanka has the fastest aging population in South Asia. So if you look at this graph, so we are in 2025, at the end of this year, probably we are reaching around 20% of our total population being more than 60 years of age. And this trend is going to continue. As you can see, in 2040, it will reach 25% and so on. So the population is becoming older. So as healthcare professionals, we need to be aware about problems we encounter in old age. It's not only geriatrician's job. I think it should be all the healthcare professionals' job to take care of the older people. And when it comes to geriatric medicine, we have a set of syndromes called geriatric giants, which we consider as the cornerstones of geriatric medicine. And falls is one of them. The others are difficulty in mobilizing, we call it immobility. Then polypharmacy-related problems, we call it iatrogenic. And urinary and bowel problems, we call it incontinence. Delirium and dementia, which is called impaired cognition. And social isolation and impaired homeostasis has been recognized as new geriatric syndromes. All right. So the list is rising. We encounter, and as you can see, the falls is one of the most common and important problem in old age. And talking about the prevalence of falls, so every second old adult fall globally, and these falls result in a lot of injuries, and some of these injuries are fatal and lead to a lot of hospital admissions and deaths as well. So as a fact, 1 in 3 older person more than 65 years fall each year. And when it comes to more than 8 years, half of the adults more than 80 fall according to the statistics during a year period. So it seems like it's a huge burden to the healthcare system. And what is the definition of a fall? So fall is defined as an event which results in a person coming to inadvertently on the ground or floor or a lower level. And if somebody is having more than 2 falls within 6 months time, we call it recurrent falls. And this is not part of normal aging. That's the first thing we need to understand. So certain complaints like falls, loss of appetite, insomnia, urinary problems, difficulty in mobilizing. Sometimes we think these are due to old age. But these are not part of old age, although these are common in old people. So falls is a disease which we need to evaluate and treat. Okay, so that's the first thing I need to convey today. Right. And falls can result in a lot of problems. There are physical consequences as well as psychological problems. Falls can result in minor injuries like skin tears and can cause major problems like head injury, subdural hematomas, internal bleeding, as well as fractures. Out of all the fractures, hip fracture is the one which has poorest prognosis, which about 30% of the people who develop hip fracture having mortality within 1 year period. And it also has psychological consequences. Fear of falling being the most prevalent psychological consequence. And these patients who have one fall develop fear of falling, and this increases risk of further falls. All right. And then also this related to depression, anxiety, and a lot of other problems like social withdrawal. Why do older people fall? That's what we are going to discuss today. So before going to discuss this, I'll show you a short video about a fall. Okay, look at this video, and because you might not be familiar about what type of falls we are going to discuss today. These are the typical geriatric falls. Right. Okay. You will see it again. Okay. So what do you think happened there? Was it accident? Was it in addition to accident? Was there anything else? So what is the cause for the fall? Is it just a stumble, or is it a mechanical fall? You think the patient slipped and fell? Was it a syncope or seizure? Or was it a multifactorial geriatric fall? You can put your answers in the chat box. So one answer you can obviously exclude because the topic of the lecture is not just a stumble, isn't it? Right, 5. All right, most of the people think it's a multifactorial geriatric fall, which I agree. Great, good start. Right. So let me give you another history. This is about a patient who is 80-year-old who is admitted to accident service following a fall last night. And he tells you that he might have tripped over something and fell on the ground while going to the kitchen. And it was dark and he could not remember where he left a walking stick. His walking stick so proceeded without, and still described lightheadedness just before the fall, which he often gets on standing. Following the fall, he got severe pain in the right hip and was unable to get up, decided to lie on the floor until help arrived in the morning. In accident service, he was found to have right side hip fracture. So looking at the history, can you identify falls risk factors? Now, I think most of the people agreed the previous fall was multifactorial geriatric fall, isn't it? So in this history, can you identify the falls risk factors? What do you think are the falls risk factors? Yeah, so as you can see, the patient used to walk around with a walking stick and has not been using the walking stick at night, and the environment is dark at that point, and he has developed postural illness, probably due to postural hypotension. And similar to the previous scenario, you can see there are a lot of factors contributing for the fall of this older person. All right. So that's the nature of geriatric fall. We call this multifactorial geriatric fall. All right. Let's move into another example just to clarify this further. This is about a 70-year-old gentleman presented to geriatric clinic with 3 falls over last 1 month. And after each fall, this patient was found on floor unconscious and then brought to ED. And in ED, the wife has told patient has had brief shaky movements in upper limbs and urinary incontinence and seems to be having long period of confusion after waking up in the emergency department. Patient can't recall the episodes. What do you think happened here? Is it a multifactorial geriatric fall? Seizure. Yeah, I can see a lot of people. Uh, yeah, got the correct answer. Yeah, it sounds like a seizure. So what I want to highlight is not every fall is multifactorial, but vast majority of falls are multifactorial. But some falls can be seizures and syncope as well. All right. So how do you categorize falls? Right. So falls can be categorized according to the circumstance of fall or according to the mechanism of fall. So we categorize them as having indoor falls, outdoor falls, and falls with loss of consciousness, falls without loss of consciousness. And when it comes to mechanism, the terms like mechanical falls, right, and are not used anymore, right? So I see a lot of uh, doctors use the term mechanical falls. It doesn't give you the mechanism of the fall. So those type of terms are no longer used, right? So rather than we use terms like multifactorial geriatric fall. If the fall seems to be due to many reasons, right? And if it's due to clear sleep or trip, we use clear sleep or trip. And sometimes these falls can be due to external forces, right? And sometimes, as in the previous example, acute medical problems like seizures, syncope, and hypoglycemia and other problems can also result in falls. So that's how we categorize the mechanism of fall. And when it comes to uh, understand the mechanism and the possible contributor factors and consequences of falls, we need to take a proper falls history. So this has to be a part of our routine history when it comes to uh, seeing older people, because older people they do fall, and we need to ask in our history whether they had any falls during last 6 months or so. And when if they have falls, then we have to get a further history about what type of fall they had. So similar to a seizure, we divide falls history into three parts: pre-fall, fall, and post-fall. And during the pre-fall assessment, we ask questions to elicit whether they have any kind of pre-syncopal symptoms before they had the fall and what activity they were doing prior to fall. For example, possibly due to postural giddiness. All right. And sometimes some people get fall while they're turning their head. All right. This could be due to carotid sinus hypersensitivity. Some people with neurological problems, they fall during turning. And people with cognitive impairment, they fall during multitasking. Right. So likewise, what they were doing before the fall is quite important. And their general health and general mobility level, we need to ask, and we need to look for evidence of acute illness. For example, people with infections at old age, they might not present with fever. They might not present with typical symptoms, but rather they will present with symptoms like fall and confusion. Right? So always we need to exclude acute illness in a patient who present with a fall. Right? And the fall phase need to ask from the patient whether they can remember falling and whether there's any eyewitness. It is very important to exclude sinister problems. And during the post-fall period, we need to evaluate whether the patient has had any injuries following the fall and whether they had a long lie on the floor following the fall and whether they have any symptoms suggestive of a seizure or a syncope. All right. And coming into the long lie, so the definition of long lie is if a person lie on the floor after the fall for more than 1 hour, we consider that as a long lie. If somebody is having a long lie, there's a risk of developing certain complications like rhabdomyolysis, aspiration pneumonia, and infections and pressure sores. So these type of falls are considered as high risk falls. All right. And most of these patients who fall, they might not be able to get up. Right. So they will sometimes lie on the floor until help arrives. So it's common to have a long lie in most of the geriatric falls. Right. When it comes to falls with loss of consciousness, we need to think about certain sinister problems like seizures, syncopal episodes, vascular events, and sometimes the patient might lose consciousness after falling and hitting the head. So how do you differentiate? You usually ask them whether they can remember head hitting on the ground. So if that's the case, possibly they might not have lost consciousness before the fall. Maybe they lost the consciousness after hitting the head. Right? This type of falls again has to be considered as sinister falls, and you need to evaluate them for underlying medical problems and head injury. All right, this is what I was talking about, long life, and this duration of 1 hour is a rough value, and this type of injuries like pressure sores, rhabdomyolysis depends on patient's condition as well as the condition of the floor. If they fallen on a concrete floor, the chances of getting a pressure sore even duration less than 1 hour is high. So and things like hypothermia can be a problem if they fall on outside in the garden, right? Maybe in the evening or night. And so if they had a long life, we need to explore problems like that, right? And talking about further evaluation, after taking a proper false history, then we need to move to examination. And then postural hypotension is one of the very common causes of falling in old adults, and usually not checked in the normal clinical setting because it takes time, and you need to follow the correct technique. Most of the time, we don't measure for postural hypertension, and this goes unnoticed, right? And sometimes these patients undergo unnecessary interventions like Holter monitoring sometimes, because when you can't find a cause for the syncope, sometimes they undergo unnecessary interventions, but it could be due to simple postural hypertension, which is very common in old age. And checking for the medications is quite important. There are a lot of medications which can give rise to falls, which I will describe later. And checking gait and balance and overall muscle strength are important, which we usually do in the geriatric clinics. I will explain how to do this. And evaluate for cardiac and neurological diseases if you can't find any other cause, especially. And the common causes are aortic stenosis, Parkinson's disease, and peripheral neuropathy are common causes of falls. And these are also risk factors of falls. So we need to examine their vision, hearing, and ask for urinary incontinence, mood, cognition, examine their feet and footwear, get and assess their nutrition level, do some basic blood test and ECG. And if it if the patient has high risk of syncope, then we need to consider about doing echo Holter monitoring. And if they have high risk of seizures, we perform EEG where necessary, not for all the patients. Okay. So as you can see, this assessment is quite complex. And we have this type of special assessment called comprehensive geriatric assessment. It's a microscope of the geriatrician, all right? Comprehensive geriatric assessment. So all the geriatric patients who had a fall need to get a comprehensive geriatric assessment done, ideally by a geriatrician or a trained doctor in a geriatric setting to identify these multiple risk factors which could have led to the fall. Because if you don't correct these multiple factors, you can't prevent fall. So they need to undergo something called a comprehensive geriatric assessment. Right. So further evaluation. So for the gait evaluation, we usually do in our clinic bedside gait evaluation. But if you are worried about their gait, if you want to get further details about the gait, we can refer to gait analysis. Right. So yeah, this is done by the physiotherapists. And we do tests like time up and go test, and we can measure gait speed. And we do something called chair ice test, which we do to identify the strength of lower limb muscle. This is how you do the chair rest. Ask the patient to stand 5 times, and we measure the time taken. So with that, we can get an idea about their lower limb strength, right? So that's a validated test to diagnose sarcopenia. Right? Sarcopenia is a problem in old age. And then four-stage balance test. So these are very simple tests, but give a lot of information about their muscle strength and balance. And if we need to further assessment, we can do a work balance scale as well. And walking while talking test is also a very simple test. So it's not easy to talk while walk actually, for especially for older people who have cognitive impairment. So if they are having difficulty in walking while talking, that's a clue to screen for cognitive impairment. Right? That's a very useful test as well. Right. So we discussed about the false classification and what are the common causes for falls, as well as how to do a basic assessment for these patients who present with falls. And talking about risk factors, we divide these risk factors into several categories. Right? So there are intrinsic risk factors, there are extrinsic risk factors, as well as there are situational risk factors. Sometimes we categorize them as predisposing acute and chronic host factors, as well as precipitating environmental and behavioral factors. So always the goal is the interaction between these risk factors, intrinsic as well as environmental. Okay? Right. So this multifactorial nature of geriatric falls is one important message of this lecture. All right. So most vast majority of geriatric falls are due to multiple factors. Right. It's a multifactorial, not due to single reason. Right? Minor amount of geriatric falls could be due to other sinister problems like, as we discussed, seizures, syncope, vascular events, hypoglycemia, and so on. Right. So what are the intrinsic risk factors? So as you can see, gait balance problems, peripheral neuropathy, vestibular problems, muscle weakness, vision impairment, medical illness, all right, and age itself, right, orthostatic hypotension, dementia, drugs, loads of intrinsic risk factors which are very common in old age. And there are also a lot of extrinsic risk factors which are the environmental hazards, and there are situation risk factors as well. And these intrinsic and extrinsic risk factors, they interact with each other and make a person vulnerable to a fall. And there are often a precipitating cause like a slip or a trip, and then which result in a fall. Right. So mostly we look at the precipitating cause and we think the fall is due to this. But there are a lot of risk factors underneath which make a person vulnerable to the fall. Okay, so that's what we need to identify. So these are called multifactorial geriatric falls. So similar to other geriatric syndromes, fall is also a multifactorial thing. All right, so most of the old age problems are multifactorial. All right, that's a take home message. Right, talking more about intrinsic risk factors. So as you can see, so we have discussed these things. In every system, most the older people, they have some problem, and these problems accumulate and they interact with each other. Talk about the mobility, sensory functions, cardiovascular, psychological, urinary, and bowel, nutrition, metabolic problems. There are vast amount of problems. Right. So talking about the false risk increasing drugs, we call them FRIDs. All right. And that's also very important thing to evaluate when it comes to falls in old age. There are certain drugs which can drastically increase the risk of falling. So we call them FRIDs. Right. So drugs like alpha blockers and especially uh, antihypertensives as well as prostate relaxing agents can cause postural hypertension and falls. Anticholinergics are considered as highly undesirable in elderly. Right? It can cause a lot of problems like confusion, dry mouth, constipation, blood vision, urinary retention, a lot of problems. So we consider anticholinergics as hazardous drugs in elderly, and we need to de-prescribe when you see anticholinergic drug. And then antidepressants. So antidepressants can improve mood. So that is a good effect, but in the other side, sometimes it can contribute to the risk of falling. So we need to carefully evaluate and see whether we can de-prescribe these medications. And anti-epileptics, antihistamines, antipsychotics, and sedatives and benzodiazepines, centrally acting antihypertensives, diuretics, opioids, and drugs using for overactive bladder. Usually they are anticholinergics and vasodilators in cardiac disease. So these drugs are called post-increasing drugs. So most of these drugs, sometimes they might be indicated. We call it appropriate polypharmacy and might not be able to de-prescribe. All right, but we need to consider deprescribing if someone who has recurrent falls are on these medications. All right. Talking about sarcopenia, we discussed about the decreased slowly muscle strength. This is due to a disease called sarcopenia. So your body composition changes as you age. As you can see, your muscle mass will start to go down after 40s. It starts from 40s. Okay. If you look at this image, you can see the muscle mass of the thigh muscles. And you can see the skeletal muscle mass in the cross section. And when the person gets older and older, what happens? The muscles are replaced by fat. This is called sarcopenia. All right. So sarcopenia is a strong predictor of falls as well. And if you want to develop muscles after 50s, you have to concern more about the lower limb muscles. So these are directly correlated with falls risk. And talking about postural hypertension, so I mentioned earlier, this is something very simple, but we don't do often for people who present with falls. And most of the older people have this problem as well. So how do you measure orthostatic blood pressure properly? Have the patient lie down for 5 minutes, and measure blood pressure and pulse rate while patient is supine. Get them to stand, measure blood pressure in 1 minute as well as in 3 minutes. You need to repeat it, okay? Because there's a group who develop delayed postural hypertension. Okay? If blood pressure drops, systolic blood pressure drops more than 20 and diastolic blood pressure drops more than 10, we consider as significant postural hypertension. And sometimes if patient develop giddiness, even with lower blood pressure drops, we need to consider as significant, right? So it's not the 20 and 10 are not magic numbers. Sometimes they can be, 15 millimeter mercury drop if patient develop giddiness. We need to consider that as significant postural hypertension. Right. So what is post-fall syndrome? So we talked about fear of falling. When somebody falls, what happens? They develop something called fear of falling. This leads to lack of confidence and further restriction of daily activities. And again, a lot of other problems like social isolation, depression, as well as deconditioning of the muscles and develop more dependence. This is called post-fall syndrome. So, the same thing, fall result in fear of falling, then less activity, decreased muscle strength and balance, and increased risk of falling, again fall. So this is kind of a vicious cycle. Okay, it's not only the intrinsic factors, but there are a lot of extrinsic factors which can contribute to falling. So can you look at this image and identify extrinsic risk factors for falls? You can see the older person sitting in the armchair, another person coming down the stairs. So what are the falls risk factors? You can put in the chat box. Sleeping carpets, yes. Cables. Yeah, stairs. There are no railings in the stairs. You can see. No railing. Wires, pets. Yeah. Electric wires, carpets. Excellent. Yeah. Yeah. So as you can see, this home environment is not suitable for older persons living. You can see pets everywhere, wires going across the room, carpets, they are not attached to the floor, right? And there are no railings in the stairs. So if a person is having a lot of intrinsic risk factors, when they are in this type of a environment, they are at risk of huge risk of falling. All right. So this is a interaction between intrinsic risk factors as well as extrinsic risk factors. All right. So when it comes to extrinsic risk factors, it's not only in your home, but also in institutions, outdoor. There could be a lot of risk factors of falling. So as you can see, clutter, unsecured carpets, unstable furniture, poor lighting, low toilet seats, pets, slippery floors can be risk factors at home. And when it comes to institutions like hospitals, there are a lot of other risk factors as well. Right? And when it comes to outdoor, like some things like uneven floor, poor lighting, and slippery floors can be risk factors of falling. So these are the external risk factors of falling. When it comes to situational risk factors, so certain behaviors like lack of exercise. can increase the risk of falling over time. And high risk activities are also sometimes, if you under evaluate your risk of falling and take high risk activities, and then you are at risk of falling. The alcohol intake is a risk factor of falling, right? And inappropriate use of assistive device is a risk factor for falling. And also sometimes people use bifocal glasses. This is also a risk factor for falling. And uh, unsuitable footwear, worn out footwear is a risk factor for falling. There are a lot of situation risk factors as well. So we need to do a comprehensive geriatric assessment to identify these intrinsic, extrinsic, and situation risk factors. And as I told before, in one patient, there are a lot of risk factors, and these risk factors interact with each other and increase your risk of falling. If you have one risk factor, certain studies have shown you have 20, maybe 27% of fall, risk of falling. But if you have four risk factors, this risk of falling increase up to 78%. And one risk model, they show having muscle weakness, balance problems, and more than four medications. If you have one, you have 12% of risk of falling. If you have all three, you have 100% risk of falling within, if you have all three. These risk factors, they accumulate and they interact with each other. That's the important thing to understand. Right. Okay. Now I'm going to show you some more videos, and if you could put answers in the chat box about the mechanism of fall, what you think the mechanism of fall is. Right. Okay, what do you think is the mechanism of fall? Three different mechanisms, or are they multifactorial falls? Yeah, multiple risk factors. Slippery floor would be a contributor factor. There's a pet, unstable posture, gait abnormalities. Okay, good answers. So ultimately, how do you categorize this fall? Is it a trip and fall, slip and fall, or is it a syncope, seizure, or is it a multifactorial geriatric fall? Yeah, I think most of the people think it's multifactorial geriatric fall. Correct answer. Yeah. Yeah, slippery flow could be a contributory factor, but as you can see, there are a lot of other problems. The patients are not very stable to start with. So if you do a comprehensive geriatric assessment in these three patients, you might find a lot of problems. Joint problems, sarcopenia, balance problems, right? Urinary problems, vision problems, hearing problems, medication problems, multiple problems. So that's why we call them multifactorial geriatric faults. Let's move into the other one. Right, look at this one. What happened there? Is it a multifactorial fault? It's more like a slip tempo, isn't it? It's a slip tempo. Yeah, slippery. Yeah. It's clear slip. We call it clear slip. This one. Right. So what happened there? Probable slip tempo. Right? Probable slip tempo. Yeah. Look at this one. What's the mechanism for there? We'll see it again. Syncope. Yeah. 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 Excellent. Right. I'll show it again. Right. It's more likely the syncope, isn't it? So not all the falls are same. Get this unfortunate one. What was the problem there? The last one. that's an environmental hazard, isn't it? Cognitive disorder. Exactly. Exactly. So these type of environments are not elderly friendly, right? So clearly there are some, you know, it's not due to carelessness. It's mainly due to, I mean, it could be due to cognitive impairment, visual impairment, cognitive impairment. All right. So these are not elderly friendly. All right. Right. So that's a example of a environmental hazard, as well as possibly patient might be having some cognitive impairment as well. Right. Okay. Now a case discussion again. This is about a patient in her 70s, and she reports having 6 falls over last 6 months, and 3 of them were in the last week. So this patient is getting recurrent falls. Right? She thinks she tripped over a carpet in the bedroom while rushing to the bathroom. She could not recall the circumstances of her previous falls. She lives with her daughter and stays alone during the daytime. Daughter says that Mrs. Pereira has been prescribed a walking aid which she does not like to use. Right? You can see there are certain risk factors you can see even in this short history. Right? So what do we do in this type of patients? We do something called a comprehensive geriatric assessment. So this is how we do a comprehensive geriatric assessment. All right. So you can see her past medical history. She is having certain medical comorbidities, right? Like diabetes, high blood pressure, dyslipidemia, osteoarthritis, incontinence with huge risk factor for falling. These patients are rushing to the toilet most of the time. Insomnia, glaucoma. All right. These are the medications, right? And we do screen for vision, hearing. We do balance screening, time up and go test, PRIS test is prolonged, right? Time up and go test is prolonged, impaired cognition. This patient is at risk of malnutrition. There's high risk of fractures according to the FRAC score. Having urgent incontinence. Feet has peripheral neuropathy. There are some social problems which might have, worsened the situation for her. And when you look at the blood pressure, there's a postural blood pressure drop and kyphotic posture. There are some medical problems. So HbA1c 6.2 is quite low for this patient, considering her frailty and other risk factors, right? So, to strict glycemic control and hyponatremia and hypokalemia, anemia, and low vitamin D, very common problems in old age. And X-ray has some risk factors as well. So, looking at the drug chart, can you identify the false risk increase in drugs here and put in the chat box? Sulfenazine, excellent. It's a drug which we use for urinary urgency, but it's an anticholinergic drug. Yeah. So anticholinergics are undesirable in elderly, I highlighted earlier, and can increase the risk of falling. Any other medication? Alprazolam. Excellent. Sedatives. Amitriptyline. So just to tell more details about amitriptyline, so a lot of patients are on amitriptyline actually, which is a highly uh, undesirable drug in elderly. Okay, for many reasons. Amitriptyline is a highly anticholinergic drug. All right, it also can cause postural hypertension. It also can cause sedation. All right, so a lot of problems with amitriptyline. So we used to de-prescribe amitriptyline quite a lot. Right, the only thing is you can't stop amitriptyline suddenly. They develop uh, because they are so used to amitriptyline, right? And you need to wean it off gradually. Okay. Right. And having to get more than 5 or more medications is called polypharmacy, right? And whatever the drugs patient is on, if they are on more than 5 or more medications, it's an independent risk factor for falls as well. All right. Okay, excellent. So thiazide diuretic. So AC inhibitors is also considered as a risk factor for falls in by certain geriatricians because certain research show it can increase risk of postural hypertension. Right? And Panadine has codeine, so it's risk factor for and increase the risk of falling. Glycoside can cause hypoglycemia, and HbA1c is too strictly controlled, so we need to think about de-prescribing it. We need to think about weaning off amitriptyline. Probably replacing sulfenazine with a less risky drug like mirabegron, right? It's a beta-3 agonist. It is much more suitable for older people with falls, and probably alprazolam is not a good choice here as well. And no, don't forget about timolol. It's a drug which we use for glaucoma. It's eye drop, but it's also a beta blocker. So when you're on multiple antihypertensives like amlodipine, thiazide, famipril, as well as now timolol also contribute to the antihypertensive burden. All right. So when it has postural hypertension, we need to think about de-prescribing medications as appropriate. All right? We can't stop everything at once. Right? So we need to define the goals of care, what targets we are going to achieve, what blood pressure we are going to achieve, what blood sugar we are going to achieve. All right, and center of everything, what the patient needs, right? What's his priorities, okay? And discuss the personalized care plan with the patient. Okay? This is how we do a comprehensive geriatric assessment in a patient with high risk of falling. Right now, yeah, in that situation, what are the false risk factors? There are a lot of intrinsic risk factors identified, and some extrinsic risk factors, and some situational risk factors. All right. And how do you prevent a fall? We need to correct each and every component of this patient. Otherwise, it's difficult to prevent a fall. That's why falls prevention is so hard. Right. When it comes to management, so as we discussed, we need to first manage the acute problems, acute injuries, and medical complications. And if the suspected seizure or syncope needs evaluation, and we need multi-dimensional interventions to correct these multiple risk factors. For this, we need a multidisciplinary team. Especially physiotherapy is quite helpful, especially if patient is having low limb muscle strength, sarcopenia, and poor balance. So they can do muscle strengthening as well as balance training. And occupational therapy is quite important to do a home safety assessment and suggest certain home modifications. And sometimes, even though we don't have, the occupational therapist can also uh, do the podiatrist job, all right, to help with correcting some foot deformities. And we need to regularly review, and not to forget about osteoporosis. I have a few more slides about osteoporosis, so I will touch that there. And old surveillance also is quite important because most of these old people, they live alone, right? So when they have a fall, unless we have a system for fall surveillance, they might, have to stay for a long time until the help arrives. So fall surveillance is quite important. So talking about the environmental modifications, so these are called handrails, right? It doesn't have to be this much fancy. I'm just showing you what handrails are. So handrails has to be installed both sides of the staircase, as you can see, getting up and getting down. All right, for getting up and getting down, you have to have handrails both sides of the stairways. All right, and when you get down from the stairways, this area should be clutter free. Right, and need to have adequate lighting. Very important. We can consider installing motion sensitive lights, especially for older people who are going to toilet at night. Okay, and having motion sensitive lights are very important. And these type of carpets have rubber back, or the carpets we can secure to and attach to floor, right? So to avoid slipping, right? And when it comes to safety in the kitchen, so you need to arrange stuff in a reachable distance to prevent the risk of falling. When it comes to bathrooms, there are certain other modifications you can do. You can install grab bars, and most of these old patients, because of the sarcopenia, they can't get up from lower seats, so we need to raise the command with a command chair raiser, okay, command seat raiser. Okay? This type of instruments can be used to prevent falls. And also these are anti-glide socks with some rubber backing, all right? And these are falls detectors. If your patient get a fall, they can press the button, and the alert will go to the healthcare provider or the family member to alert they had a fall. These type of things are important for fall surveillance. And there are some fall surveillance systems as well. So with the advancement of technology, these type of things are quite available. Right. So talking about in-hospital falls, so hospital is not a very safe environment for an older person, right? So people in hospital, they are acutely ill and they are confused, right? So they have might be having some cognitive impairment, right? And they are dehydrated, worsening the postural hypotension. They are in bed, leading to acute deconditioning and further worsening of muscle strength. So patients are at risk of falls when they come to hospital. And when you talk about the hospital environment, it's also not elderly friendly. Right? There are a lot of restraints, people can fall over the restraints, and it's very much cluttered, right? And lighting is suboptimal. There are slippery floors sometimes, right? And there are a lot of stairs. So people can fall in the hospital. Right? So this is a huge problem. And prevention is quite important. The first thing is to build awareness and identify high risk patients and pay more attention to high risk patients, monitor for falls, all right? And try to avoid falls with increasing drugs. When it comes to falls prevention, it's very important to promote healthy aging at an early stage. All right, I told you the sarcopenia starts from quite early age. So the muscle mass starts to go down from 40s. So we need to think about introducing exercise regimes, enhancing their nutrition. All right, to prevent these risk factors quite at a very early stage. So these are falls prevention strategies. And encouraging regular physical activities is quite important. So there are certain type of exercises like Tai Chi have been scientifically proven to reduce the risk of falls. Right? Now how do you identify these risk factors? You need to screen for the problems. When the patient is stepping into the old age, it's ideal to do a comprehensive geriatric assessment, screen for these problems, whether they have cognitive impairment, whether they have vision problems, hearing problems, balance problems, muscle problems, bladder bubble problems, cognitive problems. So you need to screen for this. Get, you need to get their drug list screen, and then once you identify the risk factors before they get a fall, you can correct them. Right. So that's the idea of falls prevention. So it can be individual or it can be uh, at the community level. When it's to come to the community level, so there's a WHO falls prevention model, which introduces three pillars. What are the three pillars of falls prevention? So as we are doing right now, building awareness is very important. And pillar two is identification assessment of risk factors. And the pillar three is implementing realistic and effective interventions to prevent falls in old age. All right. So this is again another slide about falls prevention. So these are the things we discussed: the regular exercise, hearing and vision check, medication check, wearing well-fitting shoes, and then the home maintaining a safe home are quite important before you had a fall. And one more thing I need to highlight to you is when a patient have a fall, that increases the risk of further falls exponentially. All right. So people who come to accident service with a fall without injury are the same people who will come to accident service with a fracture in future. Right. Because people who have fall, they have risk of developing another fall. So that's the point where we need to identify these patients and do a comprehensive geriatric assessment, identify the risk factors and correct them and try to prevent a fracture in future. Okay, in that way, we can reduce healthcare cost quite a lot. Okay, right. So we can't avoid discussing about osteoporosis when we discuss about falls because falls can result in fractures. Right. So screening for osteoporosis and treating is very important. And people can get colles fracture, then vertebral fracture, and then ultimately it can lead to hip fracture. This is called osteoporotic journey. Okay, so how do you screen for osteoporosis? Use FRAX score. So we are a low resource country. You might not be able to use an DEXA scan for each and every patient, but FRAX score is validated and good enough to start treatment for osteoporosis, right? And if a person is having high risk of falls, you can add 30% to the original FRAX score and get the new FRAX score. Okay, and there are some other scores like U fracture score, FRAX plus score, which also incorporates the risk of falling. All right, so vertebral fracture screening is a very simple test and it's very important. So if you get a thoracolumbar X-ray of older patient without doing a DEXA scan, sometimes you can screen for whether they have osteoporosis, right? Because we are in a low resource kind of a setting. You can see these type of things like wedge fractures are suggestive of diagnostic of osteoporosis. Right? So you can straight away you can start treatment. So doing a thoracolumbar X-ray is a very simple and quite important test to do. Right. So this is the osteoporotic journey I was talking about. Some people develop polys fracture, they develop multiple vertebral fracture, ultimately which result in hip fracture. So yeah, when you develop hip fracture, they have huge amount of complications, including 30% mortality within 1 year. And not only osteoporosis, osteopenia is also important. Now, sometimes I see patients who have DEXA scans done, who have osteopenia, but they are not on treatment. But if you look at this graph, so when somebody is having osteoporosis, so the fracture rate is quite high, right? For example, if there are 100 patients with osteoporosis, maybe 60% of them is getting osteoporotic fracture. But the rate is not as high for people with osteopenia. But because the number of people with osteopenia are quite more than number of people with osteoporosis, the incidence of fractures are highest among people with osteopenia. For example, the highest incidence of fracture is patient with osteopenia, even though their fracture rate is low. Right? So we can't exclude people with osteopenia, especially if they have high risk of falling. So do a Fraxco in this patient if they're having uh, osteopenia in DEXA scan, but do a Fraxco if Fraxi side, we need to consider treating these patients. Right. So there's one new concept called osteosarcopenia, right? Because now this, as you grow old, your bone density goes down as well as your muscle mass goes down. Right? And we develop this condition called osteosarcopenia. Why osteosarcopenia is important? As you saw, people with osteopenia are having high risk of fractures, and people with sarcopenia are having high risk of falls. So if you have osteosarcopenia, this is the group who will fall and develop fractures. Right? It's very important to detect osteosarcopenia and treat both of them accordingly to prevent falls and fractures. These are some studies done in National Hospital. As you can see, fractures are mainly due to falls. They are not due to RTAs in when it comes to old age. So 95% of all fractures coming to the accident service, if you are a female more than 60 years, are due to falls. RTAs accounted only for about 4% in this study. Right? So by far, the commonest cause of a fracture in old age is a fall rather than RTA. Right. So this is what I was talking about. 90% of hip fractures are associated with falls, and hip fractures are associated with lot of trauma. This is another study done in Sri Lanka regarding the outcome of hip fracture. And as you can see, during admission, 1 month and 3 months and 1 year, mortality was about 8.5%, 14.5%, 21%, and 35%. So 35% of people who develop a hip fracture has died within 1 year. So it has huge amount of mortality. So how do you prevent this? Prevent falls and treat osteoporosis. Right, okay. I think we have come to the end of the talk today. So in summary, these are the take-home messages I want to you to take. Falls are common among old adults, right? It's a very common problem. Half of the old adults, more than 80, falls within 1 year. Falls are associated with high degree of morbidity and mortality. And causes are multifactorial. It's not due to single reason. And they need a comprehensive geriatric assessment to identify these complex multifactorial risk factors. And we need multidimensional interventions to prevent a fall. Thank you very much. If you have any questions, I am happy to answer.
So, first of all, we thank Dr. Sithira for his lecture, which was quite overall comprehensive. And just let me go to the questions. We have certain questions which were asked before this lecture also. One is most of the questions were answered by you during your lecture. One question I think may be significant is, do all geriatric patients need admission following a fall if there is no head impact?
No. So they don't need admission unless there's an acute medical problem, but they need all the patients with falls need a comprehensive geriatric assessment. So need to be referred to a geriatric service ideally.
Okay. Then, what are the first aid measures to be taken at a home setup?
Yeah, home setup first. Exclude fractures and head injuries. Those are the main two things I would advise to do. person is conscious, and if there's no major head impact, then we think it's quite safe. And but if somebody is on anticoagulants, and even with mild head impact, there's a risk of developing intracranial bleeding. So need to evaluate for intracranial bleeding. And if you can safely exclude fractures and head injuries, then these patients can be reviewed even as outpatient.
Okay, thank you. Then another question: what in the cases of unexplained recurrent falls, when should we consider referral to a specialist?
Yeah, so falls, as I told before, is not part of aging. Falls is a disease. If someone is having recurrent falls, definitely they need to have a comprehensive geriatric assessment to identify the falls risk factors. So need to refer to a geriatric service. No doubt about it.
Then what is the part of vertigo in falls in older adults?
Yeah, so giddiness sometimes is due to vertigo. So vertigo is common because diseases like BPPV and some other problems can be common in old age as well. So it's a false risk factor, but I need to highlight most of the patients with so-called vertigo are not having true vertigo. They are having giddiness due to some other problems, especially postural hypertension. So these patients take a proper history and evaluate for postural hypertension, which is a reversible and treatable thing, which can go undetected and ultimately result in faults.
Then another question: does depression leads to falls in adults?
Yeah, so it lead to falls in adults. The depression, how it causes falls is very complex, and but it's a recognized risk factor for falls. And antidepressants is also a risk factor for falls. So that's why I told we need to sometimes carefully handle. So if somebody is depressed, definitely you need to treat with antidepressants. But thing is, sometimes people are on antidepressants for years and years, even after the mood improved. These type of patients, we need to de-prescribe antidepressants.
And then from the list given prior to the lecture, one last question is: can an elderly person who is prone to falls benefit from using a walker or maybe a crutch, although clinically not indicated?
If clinically not indicated, no, but these patients need specialized assessment, including a physiotherapist assessment, and using the correct walking aid is very important. If you use an inappropriate walking aid, it increases the risk of falling. And if you don't use a walking aid, and if you have imbalance, that also increases the risk of falling. So you need to identify what walking aid matches to your problem, and using the correct walking aid can prevent falls.
Then from the chat box, some questions that were collected. What are the main things we should consider before starting drug treatment in elderly?
So it's a different topic. So there are a lot of things you need to consider. So I think we did a lecture on
Yeah, I
polypharmacy.
think it's
Yeah, in the
in the
previous.
same vein, someone else has asked, polypharmacy is more than 5 drugs. Is there any other thing
Five
named?
or more drugs. Yeah,
Okay.
5 or more drugs, including over-the-counter prescribed medications, is called polypharmacy. If you are on 10 or more medication, it's called excessive polypharmacy.
Okay, so right, you just answered the next question I wanted to ask. Is there anything for more than 10 drugs? So that is excessive. Then another person has asked, like Tai Chi, are there any programs in Sri Lanka where these elders can
So
go?
Tai Chi is a very good and recommended by World Falls Guideline as a way of preventing falls. Unfortunately, there are few Tai Chi therapies in Sri Lanka, but they have been done in very few private places, not in government sector.
Okay. Then in Sri Lanka, up to where can we refer a patient for comprehensive assessment?
Geriatric clinics. So there are geriatric clinics in National Hospital of Sri Lanka, which is I'm doing it, and in Kalaburi Hospital, there's a geriatric clinic run by a geriatrician, and there's a geriatric clinic in Kandy run by a geriatrician, and there are geriatric clinics in Parapitia, and then Peradeniya. There's a very good geriatric clinic, and in Anuradhapura, as well as in Kurunegala. Yeah, there are geriatric clinics.
Then can we start drugs for osteoporosis with vertebral fractures without DEXA scan? And if
Yes,
yes,
you can.
after
Yes, you
which age
can.
limit?
I mean, if you have osteopenia, and vertebral fractures, that's indication to start treatment. All right. So if you can do a DEXA scan, you have a baseline to compare with later on if you want to assess the treatment response, but it's not absolutely necessary to do a DEXA scan before starting treatment. If you have vertebral fracture, that's diagnostic of osteoporosis like a hip fracture. Right? Similarly, in hip fracture, you can start straight away on treatment. Especially in our setting, because we are low resource setting, we might not be able to get DEXA scan for each and every patient. So, if they have high risk of falls and if they have vertical fractures, you can start treatment. And then you can do a DEXA scan to see the response later.
Kind of interesting, kind of weird question. How do we manage osteopenia treatment without making him into a polypharmacy case?
So sometimes polypharmacy can be appropriate. All right. So prescribing in old age is quite tricky. So there's a principle in geriatric medicine. When you start treatment, try to stop unnecessary treatment. Right? So without reviewing the drug regime, don't start a new treatment. All right. So, but prescribing appropriate medication is a essential part in treating all people. It's not always re-prescribing. Okay, not always re-prescribing, but you need to consider re-prescription. Sometimes people might be on appropriate polypharmacy.
Another question. Can we give calcium carbonate instead of calcium lactate? And if so, what will be the dose?
Yeah, so calcium lactate and calcium carbonate both can be used during according to the patient's tolerability. Sometimes some people develop constipation for calcium carbonate and calcium, so it doesn't matter. So you need to see the elemental amount of elemental calcium one calcium carbonate and calcium lactate has, and then you need to also see what type of calcium intake patient is having in diet, right? And you need to make sure they get the total calcium requirement from diet plus supplement.
Question. Do we have to measure serum calcium levels before starting calcium treatment?
So it's always good to have serum calcium level if somebody is having osteoporosis, because for many reasons, sometimes hypercalcemia is quite common in old age because of primary hyperparathyroidism and some other, and malignancy and things. But if someone is not having symptoms, so and if they have a fracture, we can start on calcium, but monitor calcium levels. It's absolutely necessary to monitor calcium levels if somebody is on vitamin D and calcium supplements for a long run. Okay. Are there any other questions?
I'm sorry, I had
Yeah,
muted
that's
my
fine. No problem.
audio. So thank you, Dr. Sithira, for this excellent presentation. And I think this hits close to home because I think rather than patients, I was thinking about my own parents and what we can do. And maybe in a few years, we'll also be in the geriatric population. So it's a very comprehensive and holistic presentation. And thank you very much for taking the time to impart this
Good.
knowledge to us. Thank you very
Thank
much.
you so much. Thank you.